Hello and welcome to the fourth and final part of the Anatomy and Physiology video series for the urogenital system. In previous videos we've taken a look at some of the anatomy and embryology of the urogenital system as well as renal function and the bladder. In the previous video we started to look at the differences between the male and female genitalia and hormones and the pregnancy process as well. In this video we're going to take a look at the actual process of birth and finally finish with a little bit of histology and some multiple choice questions to test what you've learned over these videos. So let's look at birth first of all. Also called labour or parturition, it doesn't have a defined starting point, and most people consider labour to be the point at which there is an onset of regular painful uterine contractions with cervical change. So there are 3 stages of labour to be aware of. Stage 1 is from the onset of labour to full dilation. So this includes the latent phase up to 3 cm dilated and the actual active phase from 3 cm to 10 cm dilated. Stage 2 of labour is where there's full dilation to the delivery of the fetus, and stage 3 is what most people forget, so it's from the birth of the fetus to the delivery of the placenta. So you first have to assess the cervix. You need to assess its position, its consistency, any effacement, so is there an influx of water into the cervix to disrupt collagen fibres? Is there dilation? Is it how much is it open by? Where is the presenting part? So the presenting part is what we call the first bit of the baby that we can feel, so normally the head. The Bishop score can be used to score these different 5 elements to assess the cervix in order to give us an idea as to how far along this baby is in labour. In order to deliver the baby safely, the pace of labour must be correct. So this may be the patient's first labour, and in which case it normally takes an average of 8 hours in the active first stage, but overall just under 18 hours is normal. If it's a subsequent labour, a 5-hour active first stage, and usually under 12 hours is normal. Having said that, there's great variety between individuals and some people take much longer than others, regardless of what pregnancy it is. But the general rule of thumb is that subsequent labour should take less amount of time than the first labour. With regards to birth itself, there should be key features of the fetus. It should engage, so the presenting part should enter the pelvis. It should descend, so the presenting part should move down the birth canal. There should be flexion of the fetal head to the narrower diameter. There should be internal rotation, so the head should rotate. Then there should be extension, which is what we term crowning. And then there should be external rotation and restitution. In terms of actual birth, it relies on 3 P's: power, passage, and passenger. The power refers to the uterine contractions and the contractions of the muscles of the anterior abdominal wall and diaphragm. The passage refers to where the baby is coming through, so the birth canal, the pelvic inlet, the pelvic cavity, and the pelvic outlet. And finally, the passenger, the fetus itself. How is it presenting and what position is it in? And don't forget stage 3, from the delivery of the baby to the delivery of the placenta. So this usually occurs within 30 minutes, involving the involution of the uterus and separation of the placenta. Physiological management of the mother is really important during this time, as well as active management, so cord traction, reduction of hemorrhage is really important. So be aware of all the postpartum risks that can occur, and the main risk usually is some form of thrombosis. In addition to that, there may also be infection. Although this is fairly rare, mothers can suffer from endometritis and mastitis following birth. In addition to this, it's important to advise the mother about contraception, so offer to start by day 21 and avoid the combined pill until 6 weeks. Postpartum hemorrhage is surprisingly common, so be aware of the risks here. Perineal trauma as well, causing stress incontinence, so pelvic floor impairment and temporary bladder weakness is really common. In the long term, breastfeeding is best for the infant, but be aware of postnatal depression, also called baby blues, where the mother can become depressed following the birth of her child. Next we should take a look at histology. And this really again is something just to go through with pictures in front of you and learn. Epithelium of course differs from males and females, and in females the ovaries are simple cuboidal epithelium, the fallopian tubes are ciliated simple columnar, and so on. In the male, again, there's differences. Look for patterns. So, for example, all of the efferent ducts, the epididymis, and the vas deferens are all pseudostratified columnar epithelium, as well as the seminal vesicle. Whereas the rate testes, the ejaculatory duct, and the bulbourethral glands are all simple columnar epithelium. And don't forget, the squamocolumnar junction is of great importance in the female, found at the external os, where the columnar cells of the uterus, here we are, meet the stratified epithelium of the vagina. So next we can look at the histology of the ureter, which is one of those tubes coming out of the kidney. In the centre we have the lumen, and this is where the urine will pass through, and it's surrounded by a transitional epithelium and a lamina propria, and this makes up the mucosa. Following that we then have a muscularis layer. In fact we have two of these. We have longitudinal muscle and circular muscle, and then after that on the outside we have the adventitia. This is the histology of a bladder, which remember is transitional epithelium on the surface, followed by lamina propria and muscularis layers again, so circular and longitudinal layers. This is histology of a renal corpuscle, and here in the centre we have a glomerulus, and this surrounding the glomerulus is the Bowman's capsule. So understanding the normal anatomy of the kidney is really important to understand the histology of it as well. Surrounding it we have the distal convoluted tubules and proximal convoluted tubules, and a parietal layer surrounding the overall outside of the Bowman's capsule. Next we have the histology of the kidney, and again this is very similar, so we can see the glomerulus in the centre here, with afferent arterioles coming in and an efferent arteriole leaving. We have podocytes, which we can see visualised here, and glomerular capillaries as well. Again we can see the proximal convoluted tubules and distal convoluted tubules around the outside, and these here are the juxtaglomerular and macula densa cells, which are responsible, juxtaglomerular particularly, for the secretion of renin. So to summarise, let's have a few more practice questions. A few of these were from the start of video 1 to see what you've learned, and then after there's 2 harder questions. So whereabouts is spermatozoa produced? So the answer to this one is the seminiferous tubules, and this is where spermatozoa is produced in the 400 to 600 highly coiled tubules, and then after that it travels to the straight tubules and rate testes. Question 2, erythropoietin is vital in the production of what? So remember, erythropoietin is produced from the kidney as one of its key endocrine properties, and it is vital in the production of red blood cells. Question 3, the uterus in females can be described as what? Again, in this simplified video, in this simplified picture here, you can see that it's anteverted and anteflexed, lying on top of the bladder from the lateral view. And now for 2 harder questions. Which element of the nervous system excites the detrusor muscle to cause urination? I'd recommend you pause the video at this point. So think about the general rule of thumb. So sympathetic is fight or flight, parasympathetic is rest and digest. And what we're thinking of, remember, is the P to pee and S to store. Okay, so the answer here, excite the detrusor muscle, cause urination. This is the parasympathetic nervous system. And the second and final question, what is the name of the connective tissue capsule that surrounds each testis? Is it the tunica vaginalis, tunica albuginea, tunica media, or tunica intima? So the answer here is the tunica albuginea. Please remember that tunica media and tunica intima are to do with blood vessels and not to do with the testes. Tunica vaginalis and tunica albuginea can easily be confused, but each testis is composed of those seminiferous tubules, interstitial fluid, surrounded by tunica albuginea. So that's everything for this video. If you do have any questions, please feel free to get in touch, and thank you very much for watching. I hope you found it useful.